Hi, it's Steph here. Welcome back to my channel. Today we're going to continue on the antimicrobial stewardship mini-series with another important ASP strategy, dose optimization. Dose optimization refers to that the dose of the antimicrobial that we're giving to our patient is optimized to the patient's clinical factors, the pharmacokinetics and pharmacodynamics of the patient and the antimicrobial regimen, and to the infection that we're treating. This is important because giving a patient too low of a dose can reduce the chance of achieving treatment success, but giving too high of a dose can also result in patient harm, such as increased risk of adverse drug events, including C. difficile diarrhea. Some of the factors that you need to consider here when you're assessing whether the dose of the antimicrobial therapy is optimal include the site of infection that you're treating. Some infections, such as a central nervous system or CNS infection like meningitis and encephalitis, requires a higher dose in order to achieve optimal concentration of the drug in our CNS in order for effective killing. The second factor that you need to consider is the pathogen that you're targeting. For example, for multi-drug resistant Pseudomonas with a higher MIC, we need to use higher doses of anti-Pseudomonal antibiotics in order to achieve the optimal PK/PD target to achieve optimal killing. Although the previous two factors already takes into account some of the pharmacokinetic and pharmacodynamics of the patient and drug, there are other PK/PD factors to consider when choosing an optimal dose. One example of this is determining which dose to use for meropenem. There are some guidelines that suggest using meropenem at a dose of 1 gram IV every 8 hours, whereas other guidelines suggest meropenem at a dose of 500 milligrams IV every 6 hours in patients with a normal kidney function. If you did a lit search on this, there was actually a study that compared the two doses head-on. This study found that between the two doses, the lower dose of the 500 milligrams IV every 6 hours maintained the same efficacy compared to the higher dosing of 1 gram IV every 8. So understanding the optimal PK/PD target of meropenem or other beta-lactam antibiotics' optimal killing effects, which is the time above the MIC, it made more sense to utilize the lower dosing of 500 milligrams given more frequently if the treatment efficacy was similar to a higher dose. This would also reduce the risk of C. difficile infection, which has been correlated with higher cumulative antibiotic dosing as well as duration. Another example of using the pharmacokinetics and pharmacodynamic knowledge of antimicrobial agent in optimizing the dose is the use of extended interval or once daily aminoglycoside dosing. Studies that have compared extended interval versus traditional aminoglycoside dosing have found that the extended interval maintains the treatment efficacy and reduces the risk of nephrotoxicity and ototoxicity. So therefore, patients who fit these study criteria and are therefore eligible for the extended interval dosing, we can potentially minimize the chance of getting nephrotoxicity and ototoxicity from aminoglycoside therapy. These are just some of the many examples. So if you do notice that there are discrepant dosing regimens recommended in different guidelines for the same indication, I would suggest that you do a literature search to see if there are studies that compare the different dosing regimens in question head-on and see what their clinical outcomes show to help you decide on the lowest effective dose that you can provide your patients. The next factor is something that pharmacists know all too well, which is making sure your dose is adjusted for the patient's kidney and liver function. Many medications, including antimicrobials, undergo hepatic metabolism and or kidney excretion. Therefore, it is important to consider a patient's kidney or liver function in order to make sure that we're giving them a dose that does not increase their risk of experiencing side effects and at the same time maintaining the efficacy. There are many references and sources out there to help you renally dose adjust a medication. Sometimes you'll just need to compare between the different sources and utilize your understanding of the antimicrobials pharmacokinetics to figure out which dose you think would be the best for the patient. I'll link you to some of the references that I know of down in the video notes below. And another important factor that you should consider when assessing whether the dose is optimal for your specific patient is which weight to use for your dosing. There's ideal body weight, adjusted body weight, and actual body weight, and assessing whether your patient is obese or underweight. For example, for aminoglycoside, it is most optimally dosed using the ideal body weight because it is not distributed extensively to body tissue and remains mostly in the extracellular fluid. Therefore, we can get away with a lower dosing using the patient's ideal body weight and still maintaining its efficacy. If you have an obese patient, you may need to look at certain references such as Sanford's, which offer suggestions on dosing and obesity, as well as the literature to see if there have been any studies assessing drug dosing and correlating it with the clinical outcome for the specific infection that that you're treating. And lastly, some drug interactions may also affect the optimal dose that you can give to your patient if the two medications are given concurrently. One example of this is caspofungin and dexamethasone. These factors are definitely not exhaustive, and although in theory, optimizing a patient's antimicrobial dosing may sound easy, you probably have now realized that it requires a good understanding of the antimicrobial and the patient's pharmacokinetics and pharmacodynamics in order to find the lowest effective dose for your patient. I hope you found this video helpful, and again, take a look at the video notes below as I'll link you to some of the references that I use to help me in optimizing my patient's antimicrobial dosing. Till next time, bye for now.